Good evening, ladies and gentlemen. A warm welcome to Learn from the Legends series, an international neonatology webinar series organized by National Neonatology Forum Kerala and Indian Academy of Pediatrics Neonatology chapter. Today, we have a legend of neonatal ventilation, none other than Prof Martin Keszler from Rhode Island, USA. To moderate the session, we have two eminent neonatologists from India. First, Dr. Nand Kishore Kabra, Director Surya Hospital, Mumbai, and immediate past chairman, Indian Academy of Pediatrics Neonatology chapter. Second moderator, Dr. Shashikant Dhar, Professor and Head of the Department of Pediatrics, GGS Medical College, Faridkot, Punjab. Now I hand over to Dr. V.C. Manoj, who will introduce the eminent faculty and with further proceedings. Over to Dr. Manoj. Thank you.
Thank you, sir. Hello, everyone. Thank you for joining us today from whichever part of the world you have joined. Today is a very special day because we have with us the legend of neonatal ventilation, Professor Martin Keszler. It is in fact a dream come true for some of us who were fortunate to learn right from the basics of neonatal ventilation from this legend. And it's my proud privilege to introduce him. Dr. Keszler is a native of the Czech Republic and a graduate of McGill University in Montreal, Canada. He is now the Professor of Pediatrics at Brown University and the Director of Respiratory Services at Women's and Infants Hospital of Rhode Island. But more than that, we all know he is the legend of neonatal ventilation who tells us newer things as the days go on. We all know him as a clinical trialist who has led several multi-center randomized controlled trials of various modes of respiratory support that have importantly impacted clinical practice. Dr. Keszler is one of the investigators in the NIH-funded Neonatal Research Network and is also very active as an educator, author and editor, including the just released, the New Year gift, 7th edition of the Assisted Ventilation of Neonate textbook. Professor Keszler is also on the board of directors of the Hippocrates Foundation and responsible for the respiratory seminars that some of us used to regularly attend, probably in the pre-COVID era. His areas of research include all aspects of ventilation. The volume targeted ventilation, that's going to be the topic today, delivery room stabilization, high frequency ventilation. He is a legend who told us that you can target ventilation even in high frequency ventilation. Then pulmonary hypertension, bronchopulmonary dysplasia, ECMO, INO, etc., etc. And he is going to talk to us today on the most relevant aspect of ventilation, targeting tidal volumes. I would not spend any more time. Let's straight away hear from the, ladies and gentlemen, let's welcome the legend of all times, Professor Martin Keszler. Over to you, Professor Keszler.
So thank you very much for that kind introduction, and I am privileged to be able to share with you this lecture. So without further ado, let me get started since we're already well into the hour. And what we will do is talk about things that hopefully you are well familiar with, and we'll get into a little bit more depth. So we, of course, all are very interested in minimizing lung injury. Lung injury is a complex process illustrated here with the events that lead a nice, healthy, happy terminal air sacs or alveolus to one that's severely injured. The process typically begins with some form of biophysical injury, and we'll argue that it's excessive stretch or volutrauma rather than just simply pressure. It can then lead to an influx of activated neutrophils, release of a variety of markers and mediators of lung injury, a variety of pro-inflammatory cytokines, for example, and that initiates the process of injury and repair. Of course, infection can trigger this process directly. Ultimately, we are trying to prevent severe chronic lung disease, the ultimate bad outcome of extremely preterm birth. And the point here is that it's an extremely multifactorial pathogenesis. It's not just one thing. The process, of course, can begin already in utero with chorioamnionitis, severe growth restriction, oligohydramnios leading to pulmonary hypoplasia. The events around the time of birth with preterm delivery and initiation of air breathing and our resuscitative efforts play a crucial role. But then there's a variety of other factors that influence on this. And the point is that no single intervention is going to dramatically reduce the risk of chronic lung disease, but rather it needs to be a package deal with all of these being managed optimally. There are a variety of things that are positive influences as well. We'll focus today on mechanical ventilation, but I just want to make the point that there are lots of other things that are very important. Of course, we deal with preterm infants for the most part, and these babies are vulnerable to lung injury because of a variety of factors. They have a limited ability to establish and maintain functional residual capacity because of all the factors listed in this slide. The most important ones probably being the fact that they typically have more fluid in their lungs being born by cesarean delivery. Their chest wall is excessively compliant, and they have limited muscle strength and endurance, so they're prone to lung injury. But the inability to establish and maintain FRC is probably the biggest problem, and we'll talk about how important it is to facilitate that and to avoid injuring the lungs in the first minutes after birth. It turns out that it is very easy to damage a newborn infant's lungs with excessively large tidal volumes. These are old data from Lars Björklund, who demonstrated that only 6 excessively large tidal volumes can negate the beneficial effects of surfactant. The controls who are not exposed to that large tidal volume had the expected improvement in lung compliance over the first couple of hours of life, whereas babies animals who were exposed to these large tidal volumes did not demonstrate any such improvement. So the point here is that it is very rapid process that can lead to lung injury. I'm not going to spend a lot of time on delivery room stabilization because this is not the focus of the talk, but simply to make the point that it is an important element and that you can begin the process of lung injury very early in the baby's career. And everything we do after that may only try to mitigate, but not necessarily prevent problems. And the point here, these are phase contrast radiographs where air is white. And it demonstrates that when we provide positive pressure ventilation without end expiratory pressure, 0 PEEP, even after 20 inflations, there is very little air in the lungs at peak inflation and virtually no air, no FRC has been established when PEEP is not used, when even a modest level of PEEP, and arguably 5 is probably not enough for most babies. After 20 inflations, you do see some air in the lungs at end expiration, so some FRC has been established, and there's much more uniform and more extensive aeration after 20 cycles with PEEP. But because this process takes a while, there was a lot of interest in sustained inflation, something that we undertook a large multi-center trial with Harish Kirpalani, myself, and Peter Davis, which sadly did not support the benefits of sustained inflation, which seemed like such a good idea, and there were preliminary data that suggested that it may be beneficial. But in fact, the updated meta-analysis, including the largest trial by far, the cell trial, suggests, if anything, not only lack of benefit, but perhaps some harm in terms of a trend toward higher mortality. So we are now involved in a trial of titrated PEEP to try to more gently establish functional residual capacity, because that remains an important goal. It's just something we have not yet totally worked out how to best do, but it's important to do that so that these babies can then support their own respiration without the need for intubation. And of course, we know that if we can do that, the risk of chronic lung disease is substantially lower. So avoiding mechanical ventilation remains an important goal, but of course, the most immature infants at the borderline of viability still almost always require positive pressure ventilation, and even babies up to 27, 28 weeks, not infrequently, after initially tolerating non-invasive support, end up being intubated. So when we do have to ventilate babies, how do we best do that? And of course, the topic of this lecture is volume targeted ventilation. And the reasons are listed here. I think most of you are quite well familiar with that. I will again reiterate that excessive tissue stretch seems to be the primary culprit, not pressure by itself. We know that inadvertent hyperventilation occurs frequently, and that hypocapnia is bad for the brain and is bad for the lungs as well. And I will show you why there is an important distinction between volume controlled and volume targeted ventilation that we talk about primarily as a prototype being volume guaranteed. So the adult type controlled ventilation is a challenge, and we'll get back to that concept in a minute. So here's some data which have been around for many years, illustrating that it is volume, it's tissue stretch. So these were studies done in small animals that had healthy lungs, and in one group there was a tight plaster cast around the chest and abdomen, constraining tidal volume excursion. Chest wall excursion, therefore limiting tidal volume, and they were exposed to progressively higher pressure. And the measurement on the vertical axis here is a capillary filtration coefficient, which is a measure of acute lung injury, essentially lung edema. So at low pressures, nothing much occurred because this pressure is not sufficiently high to overstretch tissue. But at 30 centimeters of pressure, there was already a statistically significant increase in acute lung injury. What's not surprising is that at 45 centimeters of pressure, which is of course a very high pressure for healthy lungs, there was a massive increase in lung edema. What is surprising is that despite exposure to the same high pressure, when tidal volume was constrained, there was no increase in capillary filtration coefficient, suggesting that it was volume, not pressure. In other words, that the effects, the adverse effects of high inflation pressure is mediated through overexpansion, illustrated here by the beaking of the pressure volume relationship, these overexpanded terminal air sacs. And so peak inflation pressure, which is excessive relative to lung compliance, pressure that overdistends the lungs, is what damages lungs, not pressure by itself. Here's another example, another study from many years ago that extended these observations by adding a third group, but basically the findings are similar, and it was again in small animals. And it turns out that regardless of whether very large tidal volumes were generated by positive pressure of 45 centimeters in the red bars or negative extrathoracic pressure, there was a great deal of lung injury measured by, again, essentially lung water and protein leak. Whereas when those same pressures were applied to animals in whom chest wall excursion was, again, constrained by a tight elastic bandage around the chest and abdomen, there was much less lung injury demonstrated. So again, the concept is that it is tissue overstretch. So this negative pressure results in large tidal volume without the positive pressure effect, and yet results in lung injury. So it's an important concept. So how does that translate? How is that relevant when we talk about the two different primary ways to control volume and pressure during ventilation? So when we're talking about pressure as the primary control variable, as we have traditionally done in neonates, when pressure is the independent variable, and this would be the loop, perhaps given that pressure, this is the tidal volume you get. When compliance improves, what happens? Well, what happens, since pressure is fixed and compliance has become better, the tidal volume goes up. And that may be a good thing if the tidal volume was insufficient, but if the peak inflation pressure was set appropriately to generate an appropriate tidal volume, and then compliance suddenly improves, perhaps after surfactant or lung volume recruitment maneuver, you can readily see dangerous overexpansion of the lungs, excessive tidal volume, and hypocapnia. In contrast, when volume is the primary control variable, the independent variable, so volume is set, and if the lungs are stiff, a lot of pressure is needed to generate that tidal volume. When compliance improves, what happens is that less pressure is needed to generate that same tidal volume. The volume is fixed, the ventilator adjusts, or the passive pressure goes down depending on the form of volume ventilation. So what is the difference here? There are, so this obviously would seem desirable. We like to control tidal volume in adults. This is what they do. In pediatric ICU, this is what they do, because of course you want to regulate your minute ventilation and PCO2. The problem becomes evident when we attach a very small baby to the traditional volume controlled ventilator. The trouble with volume controlled ventilation is that what's controlled is the tidal volume injected into the proximal end of the ventilator circuit. And because there will always be compression of gas within the circuit and humidifier and some stretching of the circuit, you will lose a significant proportion of tidal volume. That loss is relatively minor and easily compensated when the patient is large relative to the circuit. But when you have a very small baby whose lungs are actually less in volume than the circuit, then that loss is much higher. In addition to that, we have leak around uncuffed endotracheal tubes, so that the relationship between volume delivered into the patient's lungs relative to the volume that's injected into the ventilator circuit is very indirect and inconsistent. And typically you would end up having to set a tidal volume of 10 or 12 mLs in order to deliver a physiologic tidal volume of 4 or 5 mLs actually delivered into the patient's lungs. So this became a problem when we attempted to use volume controlled ventilation in the early days of mechanical ventilation in neonates. I'm talking about late 1970s, early 1980s. Many of you were not born then, probably. So what we all resorted to was, of course, pressure-controlled intermittent mandatory ventilation, which in its basic functionality is nothing more than a mechanical TP resuscitator. There's continuous flow in the circuit. There's a Peep valve maintaining certain descending pressure, and the expiratory valve is open. This is your T-piece, this is your thumb, this is your Peep valve, and the patient can breathe in and out of the circuit as desired during the expiratory phase. And when the ventilator cycles on, circuit's pressurized and gas enters the patient's lungs in proportion to the pressure within the circuit and the compliance of the lungs. And we're not worried about leak around the endotracheal tube because there's plenty of fresh gas available to maintain that set pressure with excess gas overflowing over the pressure limiting valve. So this is all good. This is easy. We all know how to do this. It doesn't matter that there is a large leak, which is good. And we all were convinced that pressure is the culprit. Turns out, of course, it is not. And it turns out, of course, that the problem is that compliance of the lungs can change rapidly. And we are usually not able to recognize and respond to that fast enough to avoid overventilation and lung injury. So when we do certain things to optimize lung inflation and move from this flat portion of the S-shaped pressure volume relationship to the steeper portion of the compliance curve, which is a good thing. It makes it easier to ventilate, improves oxygenation, but there is this danger that we inadvertently overstretch and overventilate these lungs. And that's a problem. So how did we come to tackle this? Many papers, publications, chapters use the term volume targeted ventilation to describe any modality that pays attention to tidal volume, conflating volume controlled ventilation and volume targeted ventilation. I make a distinction because volume controlled ventilation, as I explained to you, has certain important limitations. Volume targeted ventilation, in fact, is pressure controlled ventilation with automatic adjustment of inflation pressure to maintain a stable tidal volume. It is not the same thing. The flow pattern of volume guarantee is the same as for pressure controlled ventilation. So the curve, so here's your pressure, circuit's pressurized, flow enters and results in a certain tidal volume. So it is still pressure controlled ventilation, but this peak pressure is being adjusted in real time. Volume controlled ventilation is a different modality altogether. There's continuous flow of gas into the patient circuit, and pressure rises passively, reaching peak just before exhalation. So volume controlled ventilation is different. Volume targeted ventilation, volume guarantee is pressure controlled ventilation with volume targeting. Okay, so important distinction. The basic control algorithm is relatively straightforward. This is how volume guarantee began. There was a variety of other ways different manufacturers approached the issue, but ultimately everybody has moved to this basic algorithm, which means essentially there's an initial pressure controlled ventilator cycle. The tidal volume that results is measured, and it's compared to the target tidal volume that you set. And then depending on whether the tidal volume measured is less than target, inflation pressure will go up. If it's equal or within a few percentage points, there will be no change. And if it's above target, inflation pressure will be lowered for the next cycle. So it's always looking back a little bit. So this is another way of looking at this. And this is your pressure and volume waveform. Here's your pressure limit. So there's always a limit that you set, then beyond which you don't want the ventilator to go. Important safety and early warning system. So if this is the initial inflation pressure and results in a tidal volume that's pretty much on target, everything is good. If, however, the baby maybe breathes less vigorously, and we'll get back to that concept in a minute, despite the same pressure, tidal volume is less. There will be an adjustment to the pressure going up for the next cycle. Tidal volume is on target, no change. If it's above target, the pressure for the next inflation will be lowered. If this tidal volume exceeds the target by more than 30%, the ventilator will abort inflation at that point. So there is a secondary control, a safety feature to avoid excessively large tidal volumes should there be the danger of an excessively large tidal volume. So I want to briefly draw the contrast between something that has been actively promoted, which is neurally adjusted ventilatory assist, or NAVA, which is a great concept, but it's something that was developed for adults and now is being heavily promoted in newborns. And I have some concerns because it is a positive feedback phenomenon. So this is great. It measures the diaphragmatic activity and generates ventilator pressure in proportion to the patient's inspiratory effort. So this is sort of illustrated here. I failed to delete that other slide. So electrical activity of the diaphragm measures the effort, and with volume targeted ventilation, if the patient hypoventilates, generates very little effort, the ventilator will generate more pressure to try to maintain a stable tidal volume. If the patient breathes vigorously, resulting in a larger tidal volume that exceeds the target, the pressure will come down. It's a negative feedback. That's what volume targeted ventilation is. It recognizes the immaturity of the respiratory control in premature babies. NAVA, and there's also another similar approach, different technology, but same concept, proportional assisted ventilation. These are both positive feedback systems, meaning that if the patient generates relatively low inspiratory pressure, relatively little pressure is generated by the ventilator, and with more vigorous effort, more tidal volume is generated. It puts the patient in control, and it works great if you're an adult with mature respiratory control or an older child. But perhaps if you're an extremely immature neonate who tends to have a lot of periodic breathing depicted here, you can readily appreciate that if you apply positive feedback to this respiratory pattern, you're probably going to exacerbate these large variations, and this may result in untoward consequences. Here are some illustrations from a publication by Howard Stein, who is a big fan of NAVA in newborns, but notice the pattern. So in the adult, relatively stable respiratory activity, as you would expect, but in the newborn, the electrical activity is highly variable, and there are these scary looking peaks that may result in excessively large tidal volumes. So I love NAVA for non-invasive support. It may be useful for older babies with chronic lung disease, but I'm very worried about doing it in very immature babies. There's a bunch of observational studies, none of which were randomized control trials with important outcomes. Actually, there is one study which actually did not show any benefit, but this is what worries me. So here's the patient hypoventilating, getting very little help from the ventilator. Now breathes more appropriately, all right, appropriate tidal volume. Again, hypoventilates, not much support, and then vigorous effort on the part of the baby, perhaps disturbed by a nurse or somebody, and again, resulting in inflation pressures that may be too high. So from my perspective, volume targeted ventilation recognizes the immaturity of the respiratory control in a very preterm infant and is designed specifically for preterm infants, whereas NAVA was developed for adults and extrapolated into neonates. And we have a long history of bad things that had happened when we extrapolated things from adult to neonatal scenarios. So there are a number of benefits of volume targeted ventilation that are quite well documented by now. We and others have shown long ago that it maintains a relatively constant tidal volume. It's not completely constant because the baby is always perturbing the equilibrium. But the most important thing is that it prevents overdistension, volutrauma, and hypocapnia when lung compliance changes rapidly, as it does after we administer animal-derived surfactants. We provide some lung volume recruitment, resulting in improved lung compliance, and the baby clears lung fluid. It's important to understand that the adjustment is occurring in real time. The ventilator does not wait for the next blood gas, doesn't wait for morning rounds. It's not afraid that the boss will criticize it for making the wrong decision. It does what it's programmed to do, and it results in less need for blood gas measurement because you know your PCO2 will be stable. And it compensates for that highly variable respiratory drive of a preterm infant, as I just showed you. And there have been a number of meta-analyses of various modalities of volume-targeted ventilation. A couple of studies included were also volume-controlled ventilation, which is tricky to do, but in research settings you can do it. But the benefits seem pretty striking. The combined outcome just fell short of significance, but the point estimate suggests that a 25% improvement. Chronic lung disease, as defined at 36 weeks, was reduced by more than 25%, with this being the confidence intervals. And the number needed to benefit or to treat to have a benefit was 8, was a rather reasonable confidence interval. Severe intraventricular hemorrhage was reduced by roughly 50%, clearly quite dramatic impact. Number needed to treat 11. The combined outcome of periventricular leukomalacia or severe IVH was reduced by a bit more than 50%. Pneumothorax was reduced by 50%. Low PCO2 was reduced by 50%. Number needed to treat only 3. And duration of mechanical ventilation was also reduced. And these studies included almost 1,000 infants. So I think the benefits are pretty well documented, yet somewhat shockingly, at least in the United States, there's still some reluctance to use volume targeted ventilation. Part of the problem is people don't always have the right ventilator, but also a lot of confusion and a lot of lack of understanding and knowledge, which we learned by doing a survey paper a while ago. So it's important to regulate tidal volume, but it is equally important in terms of lung injury prevention to make sure that that tidal volume is evenly distributed throughout a well-inflated open lung. What do I mean by that? And this I've shown for many years. We all know what a radiograph of a baby with severe RDS looks like. It looks pretty homogeneous. We think of RDS as a homogeneous disease, but it's actually not so homogeneous. And we now have electrical impedance tomography images that show us this sort of thing. This is a CT scan of an animal, but we see the same thing certainly in babies. And the issue is that they're gravity-dependent differences, and much of the atelectasis occurs in the dependent posterior portions with aerated lung anteriorly. This results in a complex process referred to as atelectrauma. Some people use atelectrauma to only talk about the injury in the atelectatic portion of the lung, but it's much more complicated than that. Yes, there is damage occurring here. There's increased surfactant turnover here. There are shear forces at the boundary between aerated and unaerated lung. There is opening and closing of terminal air sacs with each cycle, the recruitment, de-recruitment injury. But perhaps most importantly, is the regional volutrauma that will occur in the already aerated anterior portions of the lung. This occurs because the critical opening pressure of these atelectatic alveoli is much higher than the pressure needed to overdistend the already aerated portion of the lung. This we know from Laplace's law. And remember, your basic physiology tells us that the pressure needed to distend a spherical structure is inversely proportional to the radius. So the larger radius alveoli are more easily overexpanded than popping these open. And so if you apply a normal physiologic tidal volume, but it only goes or predominantly goes into 1/3 of the alveoli, you can see how you're going to cause some damage. And in fact, there is experimental evidence to support that concept. This we have known again for many years. The non-dependent portion of the lung gets most of the damage. So lavaged animals, surfactant deficient, ventilated with relatively large tidal volumes, show much more injury in the non-dependent anterior portion of the lung, just as you would predict from what I just described. Similar, and this is looking at hyaline membrane score or composite lung injury score, same thing. Non-dependent lung gets the most damage. If you look at cytokines and other markers of lung injury, again, the non-dependent portion of the lung gets the most injury in these animals who are ventilated with relatively large tidal volumes. So we need to do something to mitigate this problem. And what we need to do is get the lungs properly inflated. Getting the lung to an open state is an essential component of any lung protective ventilation strategy. We don't want to be on the inflation limb of the pressure volume relationship. The lungs are somewhat atelectatic, and you're going to get that injury we talked about. Some means of getting the lung open with oscillatory ventilation, it's simply an increase in mean airway pressure. With conventional ventilation, is by and large increasing end expiratory pressure, but you also need to make sure you reach the critical opening pressure. So you need to also transiently increase your PIP. And there will transiently be overexpansion of the anterior non-dependent portion of the lung when you're at peak recruitment pressures. This is because the pressure needed to open these atelectatic alveoli is high, but once the lungs are adequately aerated, they become more compliant, and now you will have overexpansion unless you slide down the expiratory limb of the pressure volume relationship and find the sweet spot just above the critical closing pressure, resulting in a reasonably balanced degree of lung aeration. And this is illustrated here on a electrical impedance tomography scan. So we now have, at least in research mode, the ability in neonates to visualize the state of inflation of various portions of the lung. So alveolar stability is an issue in injured lungs. It's not an issue in healthy, normal lungs. But you can see with conventional ventilation injured lung, these alveoli disappear and collapse upon conventional exhalation with inadequate end expiratory pressure. So one way to keep this from occurring is using oscillatory ventilation or jet ventilation with adequate end expiratory pressure. And that's illustrated here, no collapse. We all know how that works, and that's really cool. But it turns out that you can achieve the same degree of lung protection when you use adequate end expiratory pressure with conventional ventilation. So here is a study from many years ago by my friend Anton van Kam from the Netherlands, who ventilated these animals who were surfactant lavaged, surfactant deficient, with high peak pressure, low PEEP, tremendously high lung injury. Then ventilated with oscillatory ventilation with the open lung strategy, a great deal of reduction in that lung injury score. But there was also a group conventionally ventilated, positive pressure, but with the open lung strategy using sufficiently high end expiratory pressure and a similar degree of protection. So you don't automatically need to use high frequency ventilation. It's probably easier to achieve the optimal lung volume concept with oscillatory ventilation in the presence of relatively severe lung disease, but you can, in most babies, do it equally well with conventional ventilation. Yet, much of the world has remained PEEPophobic, as I say. PEEPophobia is the irrational fear of using adequate end expiratory pressure, despite all the evidence that shows that it is lung protective. So this was a survey where they kind of looked at different regions of the world and asked what's the maximum PEEP you'd ever use and what was the typical PEEP that was used. And interestingly, the mean was our Canadian friends, and we don't have Australians, but Australians are similar. They're quite PEEP happy. Europe was sort of the lowest, and we don't really have data from India, so I can't answer that. But hopefully you are not so PEEPophobic, or will become less PEEPophobic if you were. There's no one single level of end expiratory pressure that's best for all infants, because it needs to be titrated. Individual patient care is the key. It needs to be titrated to optimize lung inflation. The best marker we have in the absence of ready availability of electrical impedance tomography is to look at oxygenation, because lung inflation affects ventilation perfusion matching, which is reflected by oxygen requirement. So if you have an oxygen requirement that's substantial and a radiograph that looks like RDS, you probably need to do something to optimize lung inflation and bring your FiO2 down to a lower level. On the other hand, once the lungs have improved, whether it's because you gave surfactant or other reasons, and the FiO2 is down at 21%, then you don't want to have a PEEP still at 8, which at times happens even in my unit. So it's important to adjust your PEEP in individual patients as their disease process evolves. And of course, there are some categories of, for example, babies with severe BPD who need much higher end expiratory pressures. Some babies who've been ventilated for a long time and being extubated from moderately high ventilator settings need quite high end expiratory pressures. So let's get back to volume guarantee and talk about some of the concepts of why one size does not fit all. Some basic guidelines we've talked about for many years is, compliance tends to change most rapidly soon after initiation of ventilation, because that's when you're resolving the diffuse atelectasis by some sort of a lung recruitment maneuver. You're giving surfactant. This is the time to avoid inadvertent overventilation. People are often busy putting in lines and not paying attention to the tidal volume. What is the right tidal volume? We'll talk a lot about that. So in your typical baby, typical preemie, 800 grams, 1,000 grams, first days of life, somewhere between 4 and 5 ml per kilo typically works for most babies, but different babies need different tidal volumes. The really small babies, infants with different conditions, which I'll talk about in a second, and certainly older infants with chronic lung disease need substantially larger tidal volumes. And I'll show you why. I'll show you the data. We have demonstrated some years ago that it works better when you combine volume guarantee with assist control pressure support rather than SIMV, because typically the SIMVs run at lower rates. If you use relative similar ventilator rate, with SIMV, it's not as much of a problem. But you may need a slightly larger tidal volume because SIMV by itself without pressure support will need a bit larger tidal volume. And of course, we want to use the pressure limit as our safety alert if compliance is changed in a bad way and deteriorated and more pressure is needed. You want to know about it. And so keeping the pressure limit fairly close to your current working pressures gives you that information. And of course, we need to pay attention to what the baby's actually receiving, not just the pressure limit. And of course, we'll talk about weaning. So what's the issue here with tiny babies? So we looked at this with a former fellow of mine many years ago, and I was at Georgetown University. Looked at a bunch of babies less than 800 grams. We did this in part because there were some people who were so afraid of the dead space of the flow sensor, they were taking out the flow sensor and flying blind, which we thought was a bad idea. So we wanted to show them that it's actually okay to keep the flow sensor in. And the tidal volume needed for normal PCO2s in the mid 40s for babies around 700-800 grams was, as was previously shown, was around 4.5-5 ml per kilo. But when you move down to the other end of the spectrum, what I call ridiculously low birth weight infants, mostly growth restricted babies that were down around 400 or 500 grams, the tidal volume needed was closer to 6 ml per kilo. And this has to do with the dead space of the flow sensor, right? The flow sensor is in line. It does add some dead space. And that dead space is proportionately more important in the tinier baby. The dead space, the flow sensors we use in the United States is about 0.8 ml. And that has less of an impact in a baby who weighs 800 grams than in a baby who weighs 400 grams. It has roughly twice as much of an impact, although you can see that the slope is not as steep as you might think because there is some admixture. But the concept of dead space is important, right? So we know that at the end of exhalation, much of the gas resident in the upper airway is exhaled gas, which moves back into the lungs first, followed by fresh gas. So in this example, if you have a tidal volume of 5 ml, a dead space of 3 ml, which is what you have in a baby who is intubated and has a flow sensor and suction apparatus in line. So alveolar tidal volume is only 2 ml here. When you reduce tidal volume, or conversely, you increase dead space by adding a flow sensor, you will reduce in this example by 50% the alveolar tidal volume. So dead space is real, and it is the explanation for why the tiniest babies actually need a bigger tidal volume per kilo, something that seems counterintuitive to some folks. So that's the concept. But what about different disease processes? So we looked at a bunch of babies with meconium aspiration syndrome and compared them to similar sized babies with more homogeneous lung disease. These were babies with a classic air trapping picture of meconium aspiration. And what we saw, again, was a substantially larger tidal volume per kilo compared to the controls. And these babies were also even more tachypnic, so that their minute ventilation, their total minute ventilation was 42% higher, highly statistically significant. Yet their PCO2 was virtually identical, which tells us that the alveolar minute ventilation must be similar, and that what we're seeing is the effect of what we call alveolar dead space, which is something we know occurs in meconium aspiration when you have a lot of heterogeneous inflation and air trapping, which is known to increase alveolar dead space. So again, different disease process. If you want similar PCO2s, you need a bigger tidal volume. And finally, babies, as they get older, tend to require higher tidal volume. This was the same cohort of babies that I showed you before, less than 800 grams. And we followed them longitudinally. If they remain ventilated, these were the number of observations here. And despite allowing the PCO2 to rise from mid-40s to mid-50s, as you would typically do, the tidal volume needed to generate that PCO2 rose significantly. And again, this is due to beginning to develop some heterogeneous inflation, early changes of chronic lung disease. And of course, when you take this out to 2 months, 3 months, the tidal volume needed is much higher than that. Finally, we looked at a bunch of babies with congenital diaphragmatic hernia because there was a lot of confusion about what the right tidal volume is for those babies. There are a number of book chapters and publications that suggest using a tidal volume of 3 ml. Again, remember that dead space concept. 3 ml is dead space, and it doesn't work. We tried it, and the babies pushed back and said, no, we need more. And again, so this was termish babies, not a huge number, but we ended up needing tidal volumes that were similar to non-diaphragmatic hernia infants, whether it was pre-op or post-op. Again, PCO2 was identical. And that shouldn't really come as a surprise if you think about it, because congenital diaphragmatic hernia babies of 3 kilo have the same metabolically produced CO2 load as any other baby without diaphragmatic hernia, so they need similar alveolar minute ventilation. And in fact, diaphragmatic hernia patients have a higher dead space to tidal volume ratio because they have only, hypoplastic lungs, but the large airways, the upper airways and upper are the same in that space. So it becomes a problem. So, but it's also important that to understand that the numbers that I just showed you, they're population means, right? They are averages with a significant standard deviation. So not every baby is going to respond optimally to those settings. So you need to obviously consider what your patient has as underlying pathophysiology. You choose what you believe based on your knowledge of the literature, what the settings should be, but then you must evaluate the patient's clinical response and look at the pulmonary graphics. It's very important to know, to listen to the baby. We don't paralyze or heavily sedate our patients, and they can tell us whether they agree with those settings. If the baby continues to be tachypnic with retractions, clearly the tidal volume we chose is insufficient. If the baby is agitated, it's probably not adequately supported. If the baby becomes apneic, baby may be overventilated. We took away the respiratory drive. So the blood gas is only to confirm after you've made adjustments in response to the baby's response to your settings. This is really important. Why is it an issue? Well, babies, again, we don't paralyze them, we don't heavily sedate them. And so the tidal volume on the vertical axis here is the result of the positive pressure from the machine and the negative inspiratory effort of the baby, which we don't measure, which we don't display on the ventilator, but it's there. And if the tidal volume is insufficient, baby will have to work harder, generate more pressure. And if by contrast, the tidal volume is, the pressure is such that it generates a large tidal volume, the baby may not need to breathe at all. And this is what's illustrated here. Here's a baby who is on volume guarantee, and there is no positive pressure above PEEP being generated. Why is that? When I first got this machine, and 30 years ago, I was like, what's going on? This is not working. And then I realized that my settings were not appropriate. So here's the baby telling us that he probably or she needs more support. Why do I say that? There are really two scenarios if you see this. If this baby is comfortable, it's not tachypneic, has a low oxygen requirement, just is breathing relatively easily, then it's time to extubate. But this baby is not. This baby is tachypneic, respiratory rates almost 70, and visually this baby was retracting and has had rising oxygen requirement. This baby was telling me that he or she needed a larger tidal volume. And if we let this continue, the baby will become exhausted and eventually will have fluctuating PCO2 as he or she intermittently fails to sustain that respiratory effort to breathe unaided through a narrow endotracheal tube. So this is to be avoided. You need to make a clinical decision. Is the baby ready to extubate, or do I in fact need to provide better support? So the title of this talk is taken from the review paper that I wrote some years ago to really explore this in more detail. So if you'd like to read all about it, there's a bit more in there. I want to briefly talk about leak compensation. For those of you who use the Drager ventilator, this is an important advance. Not all, some of the other machines that use volume targeted ventilation don't have this, and they have to be more careful. But we all struggle with the leak around the endotracheal tube in our patients. Volume guarantee and other volume targeted modalities typically use exhaled tidal volume, which is less affected by leak, but there still is leak even during the expiratory phase because it's driven by the end expiratory pressure, PEEP. So if you're using higher PEEP, you will have more leak even during exhalation. But the leak is larger during inspiration. So if you have a tidal volume going in inspiratory tidal volume measured at 6 ml, then you have a fairly large leak. 2 ml might be leaking out, and only 4 ml actually reaching the patient's lungs. But we don't measure that directly, do we? So we measure this, and we also measure the exhaled tidal volume, which in this example is 3 ml, so not as different from the volume actually in the patient's lungs as the inspiratory tidal volume. But there is some leak. So tidal volume in the lungs 4 ml, 1 ml leaks out during the expiratory phase, which is longer, and 3 ml. All right, so if we're targeting 4 ml and we're going by the exhaled tidal volume, the ventilator will increase the inflation pressure to try to make this number be 4. And in order to do that, it will actually ventilate the patient's lungs with a tidal volume a little more than 5 ml per kilo. So this could be a problem. And this is why if you have a large enough leak with volume targeted ventilation, it becomes a problem, except if you have the Drager VN500 and now the newer versions, 800 and 600, have this leak compensation phenomenon, which actually calculates the tidal volume based on the inspiratory and expiratory tidal volume measurement, and can use that calculated value of 4 ml to regulate our inflation pressure. So this is a really important advance, and it's an option. You can activate it or not. If you don't use the automatic leak compensation, which you should, if you don't use it and you have a large leak here, it's a very large leak, but that's for illustration purposes, your exhaled tidal volume is going to be measured at 3.6, and the tidal volume per kilo is tiny, would be inadequate. You would be worried, and you see the leak here. So the tidal volume without leak compensation is the measured exhaled tidal volume, and that's what's used here. With leak compensation activated, despite the same very large leak, you now are measuring the exhaled tidal volume differently. You're using the calculated value, okay? The measured tidal volume is still the same, but the actual tidal volume that the device tells you the patient is actually seeing is a normal 4.6 per kilo. What I don't like is that the waveform eliminates the visual illustration of the leak. I would like to have that independently be turned on or off, but this is important. So the calculated tidal volume works remarkably well, and it corrects even very, very large leaks. And these are some data where they looked at progressively larger leak around the endotracheal tube. Volume is on the vertical axis here, and you can see that the tidal volume with no leak was a little over 4 per kilo, 4.5 per kilo. But as leak progressively increased, the measured inspiratory tidal volume deviates progressively more. They used relatively low Peep, so the exhaled tidal volume was not as much affected, but the calculated tidal volume remains remarkably stable, up to leaks of almost 80% or so. So the leak compensation is a really cool feature and should always be used from my perspective. So weaning is automatic if we're doing it right. The baby weans herself, as long as the tidal volume is appropriate, low enough that the baby has a respiratory drive. If the baby is alkalotic, obviously self-weaning will not occur, but you don't continue to lower the tidal volume, because if you do that, the baby will have to breathe above the set tidal volume. So excessive work of breathing is to be avoided. The tidal volume the baby needs does not decrease. What decreases is the pressure needed to generate that tidal volume. And when the tidal volume is low enough, extubation is possible. And so that's all I have. I apologize. I took the full hour, but that's because we started a little bit behind, owing to that wonderful introductory video. So this is what you do when your NIH funding runs out. And if you want to read all about respiratory physiology and ventilation, this just released assisted ventilation of the neonate is the place to go. And I thank you for your attention. And I will stop share.
Thank
So
you.
it was
sir.
a wonderful talk. It was a full pleasure to listen to you, and hope we get opportunity to meet you in person sometime soon. With
Okay.
that, I hand over proceedings to my co-chair to proceed with the questions.
Good evening, sir. It was a wonderful presentation. We have got certain questions in the question and answer chat box. Should I take them now, sir?
Yeah, go ahead.
Yeah. The first question is, which mode is recommended for volume ventilation in neonates, sir? This is too broad.
Which mode? So I don't know if we're talking about excuse me, synchronized mode. I would I typically use assist control or in the first days of life, and perhaps later on pressure support, but importantly modality that supports every spontaneous breath, so that every cycle that the baby, every breath the baby takes is subject to volume targeting. If you use SIMV, only the SIMV cycles are volume targeted, and the spontaneous or the pressure supported spontaneous breaths are not. So that's why I argue that you should use assist control or pressure support as the underlying synchronized mode.
So another question is, what's your view on high frequency oscillatory ventilation with volume guarantee to avoid volume?
I absolutely love it. I no longer have to choose between oscillatory ventilation with the danger of hyperventilation and volume targeted ventilation, which I know is going to prevent a hyperventilation. There are likely some important benefits of oscillatory ventilation in terms of optimal lung, more easily achieving optimal lung inflation. And the volume targeted modalities, at least, I mean, I only have firsthand knowledge with the Draeger volume guarantee, which we did a large study that is not yet published, but we showed that it tracks extremely faithfully the target tidal volume. 96% of the time, the tidal volume was within 0.1 ml of the set target. So it works really well. It maintains a stable CO2, and you should absolutely use high frequency ventilation with volume guarantee.
Yeah. Okay. Another question is how to know what fraction of volume expansion is contributed by dead space, especially in extreme preterm babies, where the proportion of expansion of the same is very high and pressure control ventilation in the initial days appear to work better.
I'm not sure I quite get the question. Can you try that again?
Sir, what fraction of volume expansion is contributed by dead space? How would we come to know?
Oh, well, I don't think you can know. So, I mean, dead space doesn't, the lung inflation is obviously is the total tidal volume. The dead space proportion influences how much of that tidal volume it takes part in gas exchange. In other words, the alveolar tidal volume. You don't know that directly, but no, from the data available, you know that if you add any sort of dead space, if God forbid somebody adds an end-tidal CO2 monitor that increases dead space significantly, it's going to reflect your CO2 elimination substantially because you're increased the proportion of tidal volume that is dead space.
Yeah. Next question is it possible to use pressure support ventilation along with volume SIMV mode?
Yes, it absolutely is. And in fact, many of my colleagues, for reasons of inertia, I think more than anything else, prefer to use SIMV with pressure support and then apply volume guarantee to that. But as I said, it only regulates the SIMV cycle. So your pressure support is still on manual control, but the SIMV will be regulated. But of course, as you wean your rate on SIMV, you're increasingly not really in full volume targeted mode.
Sir, can we use volume guarantee mode in babies who are having extreme amount of tachypnea? Would it be possible to achieve the targets in baby having tachypnea?
Well, if the baby is very tachypnic, she's telling you that she needs more support. So yes, you absolutely can use volume targeted ventilation in a baby who's tachypnic. And you should be able to correct the tachypnea by providing adequate support. It may be a matter of inadequate tidal volume or inflation pressure. It may also be a matter of inadequate PEEP, because tachypnea is a response to a loss of lung volume at end expiration. Babies are incredibly smart. They know that by shortening the expiratory phase, they can defend their FRC a little bit better by not allowing enough time for the lungs to collapse. So you need to, if your baby is tachypnic, you need to make sure that you're providing sufficient tidal volume, but also that you're providing adequate PEEP so that the lung volume the lungs are not collapsing at an exhalation. So yes, you can use it. You need to, however, address the underlying cause of the baby's tachypnea. And then if you give adequate support, the baby will slow down.
So what is the minimum gestation in which volume guarantee mode can be used? Is there a particular cutoff?
There is no cutoff. You can use it in a 22-week baby if, God forbid, you're resuscitating 22. We just started doing that recently. Maybe not a great idea, but there is no gestational age limit. You just need to know that the really small babies need a little bit larger per kilo tidal volume. And the way I figured that out was, remember, very many years ago when I just first started doing this, I had this very growth restricted baby whose calculated tidal volume of 5 per kilo would have been 1.8 ml, but the lowest you can set is 2 ml. But it turns out, of course, because you need 6 per kilo, so for 500 grams, that works. That's 3 ml, right? So 2 ml, it still works. 2 is low enough to ventilate even the tiniest babies.
And if a baby is having tachypnea, should sedation be routinely used in patient to control the tachypnea, or do we have to go with respiratory support management only, sir?
That's my favorite hot button issue. No, the answer is no. You should optimize your ventilator support. If the baby is agitated or tachypneic, it's because the ventilator support is not optimal. People say, my baby's gases are bad because he's agitated. And I say, no, the baby's agitated because he's air hungry and you are not giving adequate support. So we almost never use drugs. We use physical means of comfort, nesting the baby, making the baby comfortable, avoiding large noises and all of that. But if you adequately supported preterm baby, they should not need drugs. Now, it's different in a baby who is chronic lung disease, who is near term. Those babies do hate being intubated, and they may need some sedation. But in your small preterm infant in the first weeks of life, you should hardly ever need sedation. You need to optimize your respiratory support.
Next question is it true to say that in presence of leaks around the uncuffed endotracheal tube, the pressure-limited ventilation is better than volume-targeted ventilation? And is there a provision of compensating these leaks in these ventilators? And is there a cutoff limit of leak after which this volume guarantee mode may not be effective?
So this question may have been posed before I got to that portion of the talk, because I think I pretty much covered
this has been covered.
So no, so it depends on the device. Not all ventilators have this leak compensation. And if you don't have the leak compensation feature, if you're not using the VN 500, 800, you probably can't ventilate a baby with volume targeted volume guarantee with a leak of more than 40%. So before this became available, we routinely reintubated babies with the one size larger tube. If you have a 50% leak, you probably need a bigger tube. It's safe. We never see any problems with that. So my rule of thumb was more than 40% leak. You probably need to do something. You can't accurately do volume guarantee when the leak is that large. When you have the automatic leak compensation, then there isn't really almost no limit. You can ventilate with a leak of 60%, and you will have accurate tidal volume measurement, provided you use the leak compensation.
Yes. So next question is there any comparison between PRVC mode versus VG mode of ventilation? Can we have same benefits with both? Yeah,
so that's an important question. So PRVC is a similar concept, basically the same algorithm. The problem with PRVC is that it was the newest version of the servo is better. The servo I did not measure tidal volume accurately. It was measured back at the ventilator as in volume controlled mode, because the servo ventilators were always adult ventilators being used in neonates and not measuring tidal volume accurately. The circuit compliance feature doesn't work well in neonates with uncuffed endotracheal tubes. If you have any leak, that measured tidal volume becomes inaccurate. So in principle, the PRVC is fine. And with the new servo N or servo U, if you use the proximal flow sensor, which many people don't, but if you use that, then you are pretty close to volume guarantee and it's fine. If you don't use that proximal flow sensor, you'll be setting a tidal volume of 10 ml to deliver 5 ml. So it's a little bit more dodgy. In principle, it works, but if you have a substantial leak, it becomes a problem.
Okay. So next question is, which ventilator we prefer for volume ventilation? Any difference if the flow sensor is at Y piece or is inbuilt like servo Mackay?
Well, yeah, that's what I was just talking about. It's a big difference. When the flow sensor is at the ventilator end of the circuit, the tidal volume that you measure is not very accurate at all, and so it becomes a huge problem. It really depends on the machine that you use is important. You need to know your machine. You need to know its limitations. I've worked with and I should give a disclaimer. I have had a working relationship with Draeger in terms of education and such things, and some grant funding. But the reason I've worked with Draeger is that their ventilators are designed for preterm infants. The servo is an adult ventilator, and it's not specifically designed for babies. It can be used in babies, but it has limitations. And so, if the only place to accurately measure tidal volume is at the airway opening at the top of the endotracheal tube. And you can do that with the servo N and the servo U. You have to, it's an option, you have to purchase separately. But if you do that, then you're okay. If you're relying on tidal volume measurement back at the machine, it's not that accurate.
So next question is, should we use this volume targeted ventilation as a rescue mode, or can we use it as a primary mode of ventilation also?
I would absolutely use it as a primary mode. Why cause harm first and then rescue? There is no reason. In fact, it's best to start right at the beginning, because that's when compliance changes most rapidly. And there's some finer points to, you can start with volume guarantee immediately and pick a tidal volume and pick a pressure limit. The important thing is if you just intubated a baby, to make sure that the endotracheal tube is not in the right mainstem bronchus, because that will potentially cause problems. But if you know your patient, we have a pretty good idea what tidal volume works. Again, depending on where you measure it, if you have the right device measured at the airway opening, you can start. And I would absolutely advocate using it from the beginning. The earlier, the better.
So next question is, how do we decide target volume in HFO mode of ventilation to start, and how do we wean it? And how
Great
it is different
question.
from conventional HFO? So
with HFOV, we have some good data in terms of what tidal volumes you typically need. It turns out it's around 2 ml per kilo in most babies. Interestingly, the same factors that affect tidal volume requirement with conventional ventilation also play that same role with oscillatory ventilation. So the smallest babies need a little bit bigger tidal volume per kilo. You might want to start at 2.2, 2.5 per kilo. The bigger babies may need a little bit less. It also depends on the frequency that you use. So if you're using a frequency of 15, you're probably closer to 1.8 ml per kilo as a starting point. If you use a frequency of 10 hertz, we found ourselves in that larger study that we just did was about 2 per kilo in most babies, but again, a little bit more in the really small ones. So there are there's some data in the literature now, and hopefully we will publish our paper soon to provide more guidance on that.
okay. So next question is, at what postnatal age do we recognize that it is time to move from RDS setting to evolving BPD settings, that is higher tidal volume and lower rates? And how do we provide lower rates with assist control of mode of ventilation?
Yeah, that's a great question. Somebody who is quite sophisticated and understands the differences between acute RDS and chronic lung disease ventilation. And once you have established BPD, the ventilation strategy is very different. And it requires slower rates and longer inspiratory time, longer expiratory times. So the transition is somewhat gradual, and it's going to be patient dependent. Some babies progress from acute RDS phenotype to more chronic disease by a month of age, and some take longer to get to that point. So it's not an abrupt change. But in fact, in these more chronic babies with established BPD, that is the one scenario where I do use SIMV with pressure support. And the reason for that is that it becomes a multi-compartment lung with fast compartments and slow compartments with different time constants. So the fast compartments are probably being ventilated with the spontaneous breathing at a faster rate by the pressure supported spontaneous breaths, and the slower compartments that take longer to fill and empty are adequately supported with the larger tidal volume, slower rate SIMV inflations. So you don't switch, overnight from acute RDS to BPD. The pathophysiology evolves over time, and so your ventilator strategy needs to evolve gradually as well.
So another question is, our experience is volume guarantee mode is noting that the machine many times gives pressure above the set Pmax and a higher rate of PIE. Could you explain how to troubleshoot this and what is your experience about this, sir?
Higher rate of PIE, that's odd, because the available evidence shows that it reduces air leak. So I don't know what machine the questioner is using. The pressure at times, if the pressure limit is set at 24, it might from time to time hit 25. I've never seen it go more than 1 centimeter above the target, about the pressure limit. So it should not be a problem. Again, my experience is only with the Draeger ventilators, and I'm not sure if we're talking about the same device, but air leak PIE is a function of tissue stretch, and volume guarantee has been shown to reduce air leak. So I'm not sure what the explanation is for the questioner's observations, but it should not. Obviously, there are other aspects to setting the ventilator settings, and perhaps it's failure to optimize lung volume and maldistribution of tidal volume if you're not getting the lung to an open state, and that could explain the air leak and the relatively high pressures being needed. So it's not, volume guarantee is an important element, but obviously there are other aspects of respiratory support that need to be optimized to avoid potentially that problem.
Next question is, any conditions in extremely low birth weight babies where this tidal volume mode is not effective?
So the scenario where it's problematic is the baby with a significant metabolic acidosis. Be that a baby who had some perinatal asphyxia, has a base deficit of 18, those babies will do their best to correct their pH and hyperventilate, right? It's important to remember that it's actually not PCO2 that drives your respiratory effort, it's pH. And a normal compensatory response to metabolic acidosis is hyperventilation. So when you try to use volume guarantee in a term baby with base deficit of 15, the baby is going to show you that flat line if they're now awake and breathing spontaneously, because they're going to be generating a spontaneous tidal volume of 7 or 8 ml per kilo, maybe more. It's also a problem. So that's one scenario where I would not use volume guarantee, because it's a changing scenario. As the base deficit corrects, the target tidal volume would have to be continuously adjusted. The other scenario are very, very preterm babies who have immature kidneys, losing bicarbonate. And if we're not compensating in some fashion, they tend to also drive their CO2 into the 30s in an effort to normalize their pH. And when they do that, again, we have trouble, because people tend to look at PCO2 alone, say PCO2 is 39. Oh, I need to lower my tidal volume target. When you do that, the baby again will breathe above the set target and become problematic. So I don't say don't use volume guarantee, but it is a little bit more challenging, because we might have to accept PCO2s that are a little bit lower than what we would normally target. It's pH, not PCO2, also that regulates cerebral blood flow. So I don't think there is a problem with allowing PCO2s in the high 30s in a baby who has a base deficit, while we're working on correcting it, maybe by adding some acetate to the TPN, which is what we typically do. But that's not a contraindication. It's just a bit more challenging. It works in almost any circumstance. Again, if you don't have leak compensation, then the contraindication is an endotracheal tube leak more than 40 or 45%. And in which case, I also say don't stop VG, just reintubate with a larger endotracheal tube and continue VG.
So there's another question about this leaks that Dr. Niku asked. Do you mean with Draeger we do not need to worry about large leaks as long as we activate this leak compensation mode. Is there a limit to that about large leaks also?
So, I mean, you would never ventilate a baby with an endotracheal tube that's so small that there is consistent 70-80% leak around the endotracheal tube. So, but the leak compensation, and at least on the bench, it works up to leaks of at least 75%. So there is no absolute limit. I would still reintubate a baby if I have a consistent leak around the endotracheal tube of 50 or 60%. That's not simply positional. I would still, and I don't expect to be able to extubate the baby in the near future. I would still reintubate baby with a larger size tube, but you can ventilate and accurately without overventilating, even with a 40-50% leak. So, but that's unique to the Draeger, I think, for the most part.
Next question is again about this setting up of the tidal volume for macrosomic babies. So it's a particular gestation. If the two babies are born with a different weights, how should we decide the tidal volume?
So the tidal volume is again, if it's a function of the underlying lung disease. So if it's similar, assuming these are both premiums with RDS, it's a size that impacts the effect of dead space of the flow sensor. So the smaller baby might need a little bit larger tidal volume per kilo. Again, these are starting points. So pick a number that seems reasonable based on what you know, but then ask the baby whether she agrees with your settings, and the baby will tell you because of how they interact with the ventilator. If the tidal volume is not enough, and baby's tachypnic, is retracting, and is dropping the working pressure down to CPAP level, then it's obvious that whatever tidal volume you chose, even if it was correct based on the literature for this particular baby, it was not enough. So individualized care.
Next question is, what is the disadvantage of volume controlled mode of ventilation as compared to volume targeted ventilation?
So the disadvantage is that you don't have direct control on the tidal volume that goes into the lungs. What's controlled is the tidal volume that goes into the circuit. And with leak around the endotracheal tube and all of that is a problem. The other potential and probably minor advantage is that the flow pattern is different, and the gas enters the patient's lungs earlier in the ventilator cycle. So there's a bit more time for interpulmonary gas distribution. But the main disadvantage is simply that you don't have accurate control over the tidal volume that's actually getting into the baby because of all that loss of volume to compression in the circuit and leak around the endotracheal tube.
So there's another question: how do we manage the PEEP during the lung recruitment, and especially after the Fio2 is decreased to less than 30%?
Yeah, so that's a great question. There is not a lot of literature on this. The only published study is by Gianluca Lista a few years ago, where he used volume guarantee and did stepwise increases in end expiratory pressure to essentially follow the same approach that has been described for oscillatory ventilation. And by keeping the volume guarantee, that automatically increased the PIP as well to maintain stable ventilation, but also to make sure that you reach the critical opening pressure. So it's the same process. You increase stepwise until you see an improvement in oxygenation, and that allows you to wean the Fio2 to less than 30%, and then you consider the lung is now open. And then you want to lower your end expiratory pressure in increments, similar decrements that you used when you went up. And you look for the point at which oxygenation begins to deteriorate, and that's been described as the closing pressure. And then you quickly go back up to that last step before oxygenation deteriorated. So it's a titration. Individual patient will end up in different places. And with modern surfactants, most babies don't need a whole lot of active recruitment because surfactants now are so good when you apply them early before you've damaged the lungs and there's not an inflammatory process going on. Most babies don't need aggressive lung volume recruitment, but if you have an oxygen requirement of 40 or 50% after intubation, you probably are not using enough PEEP, and then I would just stepwise increase that PEEP by 1 centimeter at a time until I see an improvement in oxygenation. You need to make sure that the problem with oxygenation, in fact, is diffuse microatelectasis as opposed to pulmonary hypertension, because occasionally the baby's not oxygenating well because there's no pulmonary blood flow, not because there's microatelectasis. So you want to make sure you look at your X-ray and make sure that baby really has RDS and the lung volume is relatively low, consistent with the concept of diffuse microatelectasis. And then you apply your stepwise recruitment maneuver, and then you back down. And usually you find yourself at a pressure that's at or lower than when you started.
So, sir, do you have still more time, or you need to leave for meeting?
Oh my God, it's I'm kind of running out of time, but are there any really important? My goodness, we could probably keep this going for another hour, but I don't know what you've scheduled. But I'm going to be in the doghouse with my colleagues. We're probably let me see quickly if there is a where are you email. I don't see one. Oh, here. Okay. Yeah, so they're running.
Questions pending in question and answer session, sir.
So let's do another 5 minutes or so. Are we scheduled to finish at 11:30 or whatever time you are in?
Nothing, sir. It is your prerogative. Since you are running late for the meeting, we are worried.
Let's do another 5 minutes or so, but it sounds like we could go for another hour, but we probably can't because I have another meeting after that.
Sir, how should we troubleshoot hypocapnia while on volume guarantee ventilation?
Well, there you go. So that often is a scenario where there's a base deficit and the baby is spontaneously breathing to try to correct that base deficit. Obviously, so it depends on where the pH is. If the baby is alkalotic, the answer is to reduce the target tidal volume. If the baby has a pH of 7.32 and a PCO2 of 38 or 36, then you don't want to reduce the tidal volume because the baby is just going to have to work harder. So it depends on the scenario, but that is one of the more challenging things, and we really need to try to correct the base deficit rather than let the baby struggle with with progressively lower tidal volume, and baby still hyperventilates as best as he or she can because of the respiratory drive being driven by the acidosis.
A few more questions only. Is unilateral lung injury an indication to pressure ventilate, or should we still go for volume guarantee ventilation?
So there is really no difference in terms of whether how the gas will be distributed in the lungs is going to be the same. Remember that volume guarantee is a pressure controlled mode. It's just automatically adjusting your pressure, the peak inflation pressure. There is no difference in terms of unilateral disease. The gas flow pattern is the same as pressure control. It's just going to continue to maintain a stable tidal volume. Now, if you have severe disease in one lung, you may have to adjust your tidal volume target because if you're only ventilating one lung effectively, then you probably have to reduce your tidal volume. And there are other tools you may choose to use. You may choose to use high frequency ventilation if you have severe unilateral disease and such things. But oh my goodness, we have lots of issues. We could chat for for a while longer. Go ahead, keep going.
Next question is, what is the maximum tidal volume which can go for in an ELBW baby with poor lung compliance? For example, pulmonary hemorrhage. Is there any upper cutoff limit that above this we should not increase the tidal volume?
So with pulmonary hemorrhage, what you don't need to increase the tidal volume, you need to increase your PEEP, because so-called pulmonary hemorrhage is really hemorrhagic pulmonary edema, and the goal is to increase mean airway pressure to tamponade the edema and push the fluid back into the interstitium. So, so the tidal volume, I wouldn't go up on the tidal volume. I would go up on my PEEP quite significantly, and it may be a little bit tricky to continue volume targeted ventilation if you have really bad hemorrhagic pulmonary edema. But in principle, there's no reason to abandon it. You just really want to crank up your mean airway pressure.
This is another question. Many times the working pressure drops so low that it reaches PEEP, and the baby is still distressed. So in such case, would you suggest to increase the tidal VT or remove the volume guarantee mode of ventilation?
The baby is asking for more support, right? So that's the scenario I described. If the baby's distressed because you're giving him no help, you're making the baby breathe through an endotracheal tube without any significant positive pressure. That's why the baby's distressed. So if you increase the tidal volume, the baby will relax and let the ventilator do some of the work, and that's how it's programmed to work. Baby's asking for more tidal volume.
And a couple of more questions, sir. What is the effect of keeping a baby on ventilator with Fio2 of 21%? In such a case, what drives the pressure volume on the ventilator? Wouldn't it be more appropriate to keep the baby off ventilator?
So obviously, if the baby is down to 21% and low pressures and has a consistent respiratory effort, the baby should be extubated. For some babies, it's a lack of adequate spontaneous respiratory effort. They may not have significant lung disease, but they were reintubated because of unacceptably severe and frequent apnea. But yeah, if the baby has a very, very low oxygen requirement and doesn't need very high settings and seems to have adequate respiratory effort, that baby should definitely be extubated. That would be the appropriate step.
One last question, sir. So these days, should we use cuffed endotracheal tubes? Many years ago, I wrote an editorial arguing that maybe we should revisit that question. And some people are doing it. But then Draeger came up with this leak compensation, and it became a moot point because leak doesn't matter if you have the right device. If you don't have the right device, then perhaps you should. The low pressure cuffs are probably safe, but it's still a little bit contentious. And we need more data. But if you don't have adequate leak compensation, you may consider that. The alternative is to just reintubate with a large endotracheal tube. But there's increased interest in using cuffed endotracheal tubes, but you just have to be really careful not to get pressure necrosis of the mucosa. So the questions are quite a lot, but considering your short of time,
I'm really
I
late
think
for my other things. It sounds like there is a lot of interest, and I appreciate the interest, and I appreciate those questions. This has been a great audience, and thank you for inviting me.
Over to you, Manoj, sir.
So as usual, we can't have enough of you, sir. That is with all the lectures. This is what happens. And hopefully we'll continue the dialogue a month later when we have your lecture on ventilation-induced lung injury and related aspects, protective strategies. So it is a true honor for us. By all account, it was a great evening or day, morning, or what, depending on whichever part of the area you people are listening. We all agree that it was a great discussion we had. And we just never realized so much of time has passed. Now, Prof Keszler is getting late for another session, so we'll wind up. Thank you so much from all of us, sir, for having spent your time today. Hoping to hear more from you, especially in the next lecture. Thank you, Prof Keszler.
Thank you very much. Have a great day or evening.
Thank you. I would also like to thank the moderators, Dr. Shashikant and also Dr. Kabra for moderating this session extremely well. It was a big challenge to manage the session. Thank you so much, both of you. And at the end, let me just thank all of you for joining us. This is the 53rd session we are having, and we continue this saga with the next lecture that is going to be on 5th of May on a slightly undiscussed topic, neonatal dermatology. What's new in neonatal dermatology? The ontogeny of the preterm skin. How is it going to have the clinical impact? So I would welcome all of you for this session on 5th of May. Until then, good morning, good afternoon, good evening, good night.
It's